this evening for you to go over the core lab training for the Foldax India mitral study. We're going to go off. I'm going to start off with just like a little overview of the screening committee process, because that's where this all starts as far as your relationship with the core lab and also our image repository. So I'm going to share my screen. There you go. Now, when I start slide mode, it's probably going to, I'm going to have to do a switch. There, can you see the full slide now?
Yes, Michael.
Okay, cool. Okay, so just a brief agenda overview. We're going to go through, like I said, the patient screening process, just a brief overview of that moves in directly to the CT acquisition protocol, which is the first image you're going to acquire that's going to be sent to a core lab for this study. And then we'll move into the echo acquisition protocol, which is, the meat of it, the day-to-day evaluation of these patients' valve function. And then at the end, Chris Wilson from Ombra is going to join us, and he's a consultant with Ombra. He'll go over the image repository system as far as getting your images up into Ombra, which is a cloud-based image repository that then our core labs interface with as far as getting the studies to do the analysis with. And of course, the quality of the CTs and the quality of the echoes is imperative for the quality of the reads we can do, not only in the screening process, but of course in the protocol-related data analysis of images as well. So the screening committee is a committee that we've been using in the India aortic experience as well, and we'll be using it here in the United States as well. It is the whole purpose of it is making sure we're getting the best patients selected for this study, so that we have the outcomes that are that speak to the valve itself. And so we're trying to eliminate a whole lot of other confounding factors and patients that may have so many different comorbidities that it could really impact our outcomes. So the screening is just all about patient selection and ensuring we kind of have to do preoperative planning to know the appropriate size valve before we even get into the operating room. So that's the whole purpose of that committee. The committee consists of 3 physicians from India, 2 physicians from the United States, and 1 from the EU. And then we have a meeting at least once a week, sometimes more than that, depends on how many patients are being screened. The physical meetings will be, our first meeting we'll definitely do in person and face-to-face, so you guys can all meet and talk to each other. Then after that, we usually go to kind of like a virtual, like an offline process. As far as how it goes, we need a vote of 3 votes from the committee members for either approval or denial. And being that we have 3 physicians from India, if the physician that is on the committee is also presenting a patient, of course, his vote doesn't count for that particular patient. It all starts basically with these meetings that I said, like, or once a week or sometimes more than that if we're doing the offline voting, where you're just basically reviewing they're reviewing the patient history and all the charting information, and also the CT that you upload to do the screening. And then if there's any questions, we may call a live meeting. But it all starts with uploading a CT to Ombra, along with the other patient history and medical history info that I have listed here, which goes through this form, which is a evaluation review form. You can just see the check boxes on that are pretty straightforward. Again, looking at a whole lot of things like 6-minute walk, KCCQ, spirometry, chest X-ray. Big ones are, of course, coronary angiography in the last 3 years, New York Heart classification, and echocardiogram. And then that moves into then Dr. Brent Wilson, who I'll hand it over to at this point, who's going to get that CT that you guys upload for that screening patient. And that's where the journey starts for patients in this study. So Brent, I'll hand it over to you.
Okay, thank you, Michael. And so what is shown on the slide is our CT angiography protocol for the mitral valve. And our purpose of this is so that we can obtain a high quality assessment of the mitral valve, both before and after valve implantation. And our specific goals with the protocol are to obtain images that visualize appropriate portions of the heart and the proximal aorta. A second important goal is to have good contrast opacification of the left heart with minimal opacification of the right. We want to make sure that the images are free of motion artifact and have adequate X-ray penetration and detection. And most of the time, this is going to involve doing the CT scan on a fairly recent generation scanner, but probably within the last 10 or 15 years. If it's a 64 slice or better scanner, it should be adequate. Some of the newer 256 slice or greater scanners will probably be even easier to work with and generate better images. But an important feature is the scanner has to have the ability to perform ECG-gated triggering of images.
Want me to move to the next one?
That'd be great. And so in obtaining the study, of course, take note of any contraindications to CT, such as allergy to IV contrast, and that should be noted and reported prior to obtaining the CTA, and could factor into decisions regarding the patient. The patients that are able to take their cardiac medications is able. For the CT scan, they will need an 18-gauge IV or larger in the antecubital fossa or more proximally, just so the IV can handle the flow rates and volume of contrast that will be injected. And ideally, the patient should have a heart rate of less than 85 beats per minute, probably less than 75 beats per minute or even better. And if they're much higher than that, consider administering beta blocker. But of course, have caution in patients with known congestive heart failure and an EF less than 40%. Another important factor is that the patients have a regular heart rhythm. And so if they do have frequent premature atrial or ventricular contractions, you may want to consider giving those patients a beta blocker just because of the artifacts that will be generated if there are PACs or PVCs that occur during the scan. Some of the newer 256 slice generation scanners can tolerate some of these variable parameters a little better than others and can do well with patients in arrhythmia such as atrial fibrillation, but some of the older scanners have more difficulty, so it's important to have a regular heart rhythm. Another thing that should be considered is to give the patients breathing instructions before they go in the scanner, just so they can practice taking in and holding a deep breath. That way they're not surprised and there's less chance that they will move during the scan. If the patient moves during the scan acquisition, of course, we'll get some motion artifact and the scan will not be of good quality. In terms of positioning the patient on the table, standard positioning should be employed, and that's where the patient is supine on the table with both arms above their head, and the patient should be straight. Their torso should not be twisted, and it should be centered in the middle of the scan field, and you can use the laser light markers from the CT scanner to assist with that. And then, of course, place the ECG electrodes as depicted on the scanner. And in terms of settings for the scan, so for tube voltage, the tube voltage should be set for most patients at 120 kVp. For smaller patients, less than 60 kilograms, you can decrease that to 100 kVp. And then the machine, you can use automated selection to select the other parameters. The scan direction should be craniocaudal, and then obtain scout images from the pulmonary arteries to below the heart. And then the final CTA scan, I'm sorry, from that last one, your scout images should be from the pulmonary apices, not from the pulmonary artery. So kind of a bigger scout image field. But then when you select the actual window, you can go from the inferior margin of the aortic root to below the heart. And the goal is that we want to visualize all four cardiac chambers, the mitral valve, the aortic valve, and the proximal ascending aorta, but we don't need to visualize the vessels higher up or lower down in the body. So you can limit radiation dose by selecting a scan window that's adequate for what we're trying to do. And then, of course, for the ECG part of the study, the quality of the gating is very important. And then another thing to consider is the scan should be obtained in a retrospective fashion throughout the cardiac cycle. And with Mike, are you getting an echo there?
Yeah, somebody's got I hear a dog. If anybody can mute, please. I'm not sure who it is.
I muted him.
Okay.
Thank you. Thank you.
Thank you.
So the scan should be obtained in a retrospective fashion throughout the cardiac cycle. And normally with these scans, you can turn on dose modulation, which will decrease radiation exposure and dose during systole. But in this case, we want to image the heart during systole for the mitral valve study. So we recommend avoiding use of dose modulation protocols so that we can still obtain images with adequate X-ray penetration and detection in the systolic phases as well. And then in terms of contrast agents, it's good to use contrast agents with a high iodine concentration in the range of 270 to 400 milligrams of iodine per milliliter of contrast. And we use one of these agents. We use IsoView 370. And in terms of contrast timing, when to start the scan, we use automatic bolus tracking. And with that study, we follow an area of interest, in this case in the proximal descending thoracic aorta, and then the full dose of contrast media is injected. And then when that area reaches detection limits, in this case 100 Hounsfield units above baseline, the scan is triggered and starts. And then in terms of monitoring location for this, we monitor the proximal descending thoracic aorta. And the scanning is initiated, of course, with breath holding instructions that's usually given by the machine when the machine detects opacification greater than 100 Hounsfield units above baseline in this area that you're monitoring. And for a contrast injection rate, we use between 4 and 6 milliliters per second, and that gives us a total volume of contrast injected between 80 and 120 milliliters. And then we follow that up with a normal saline chaser at the same infusion rate of 4 to 6 milliliters per second. And then we end up giving 40 to 50 milliliters total of this normal saline chaser. And in terms of data reconstruction, we would like you to obtain a few data reconstructions for us from the primary CT data. The first is we would like you to make for us a multi-phase image reconstruction set, and that consists of axial reconstructions that are performed throughout the cardiac cycle in 5% increments. So this multi-phase image would then have images throughout the cardiac cycle ranging from 0 to 100% in 5% increments. And with that, the settings we'd like are a slice thickness between 0.6 and 1 millimeter with an interval of 0.7. And in terms of reconstructing the data, you can use a medium smooth convolution kernel, such as the B26F filter or something similar. And so in addition to the multi-phase image reconstruction, we would also like you to send both best diastolic and best systolic axial reconstructions. And that's usually for best diastolic obtained at 75% of the RR interval. And then for the best systolic phase, that's usually around 35% of the RR interval. And then please make those reconstructions with the same settings that the multi-phase acquisition was obtained. In other words, a slice thickness of 0.6 to 1 with an interval of 0.7 millimeters and made with a B26F or similar reconstruction kernel. And then in terms of what images that are sent to Foldax, we would like you to at least send the multi-phase image set, which again contains the entire cardiac cycle in 5% increments. And then in addition to that, please send both the best diastolic and the best systolic phases. And that will help the core lab obtain the assessment of the mitral valve that is needed for adequate selection of patients. And I think, Michael, is that it?
Yeah, I'm good. That's it for the CT protocol. So I'm going to open it up for any questions on that portion, and then we'll move into the echo protocol. Any questions from the group?
I guess, Michael, so some of the biggest things are, I guess, one is to choose the appropriate imaging window, to make sure that the ECG gate is working well. And then also, I guess, just to make sure the patient has good instructions so that we get images without motion artifact and that the heart rate is regular. I think with that, we'll get high quality CT images.
Thank you, Brent. And yeah, like I said at the beginning, and like Brent has reiterated, the quality of these CTs and the consistency of them is imperative to us having a smooth screening process and also the rest of the trial. So, and I know you guys are great at what you do, and hopefully this information that we're imparting to you
It is.
will be helpful.
And as Michael pointed out, just we're trying to get the same consistency. I think there are a few different sites, and you know it's natural to have different protocols, which is great. We're just trying to have the same protocol throughout each site.
Exactly. Okay, so we'll go now and move over into the echo acquisition protocol. Let me get these slides up. There we go. And at the beginning of this, you know, I didn't even take the time to introduce myself because I know a lot of you already on this call. I'm Michael Dias. I'm the Director of Clinical Affairs for Foldax. And then I did introduce Dr. Wilson, who's presenting. He's Director of Cardiovascular Center at the University of Utah Hospitals and Clinics. And he is actually doing this presentation this morning for Dr. Federico Ash, who is the Director of the Core Lab at MedStar. So MedStar is the core lab we're using for all of the echoes with this study. And Dr. Ash just had a scheduling conflict and wasn't able to be with us today. So Brent was gracious enough to fill in on these slides, which he had a huge part in constructing this protocol as well. So I'll hand it over to Dr. Wilson again, and thanks everybody.
Thank you, Michael. And as Michael mentioned, Dr. Federico was unable to be here today, so we'll go through his slides, and we hopefully we catch everything that he would like you guys to know. I think it's a very good transthoracic and transesophageal echo standardization protocol, and the goal is to standardize again as much as possible from center to center and across patients. And these are some recommendations that are very good ones that can help us obtain that goal. I guess one is, if possible, would like you to use the same echo machine throughout the study, whether that's a Philips IE33, Philips Epic, or one of the GE systems, one of the Vivid systems. It'd be great if you could use the same machine throughout the protocol. And we would like to have the same sonographer perform all of the transthoracic echocardiograms, and the same cardiologist perform all of the transesophageal echocardiograms at each center throughout the study as possible. And for these studies, we'd like you to provide at least 3 beats of each view. If the patient is in atrial fibrillation, please increase that to 5. An important parameter is to make sure that the displayed ECG is appropriate on the echo images. So that may involve adjusting the ECG electrodes on the patient or changing the gain of the ECG just so that it's visible on the echo image, and that will really help with our image processing and how we trigger these images during playback. And then also please record your Doppler spectral velocity tracings at sweep speeds of both 50 and 100 millimeters per second. And when you save the images, please make sure that they are DICOM compatible. That way we can pull them up in echo reading programs and other image viewing programs. And like we mentioned, it's very important that the images contain a very good and of appropriate size ECG tracing. And then, of course, remember to finalize the exam when the study is completed. And then when you save it to export, please select DICOM as the image format.
And as simple as that may seem, while a lot of you guys on here are also research coordinators who will be in charge of uploading these images, that has been something that we've had issues with throughout the aortic study. So before you upload, like Brent said, please open the file folders and confirm it's DICOM format, because the machines that are used to read at both Brent's lab and at MedStar cannot open them if it's not DICOM.
That makes it more vendor neutral, and we can open it with a variety of software packages. And then in terms of the demographic data for each patient, please include the patient number in the study without protected health information. So please don't put the patient's name on the study. And then also it's important to ensure that the date on the echo machine is correct. Sometimes if it's a power outage or maybe the machine has been repaired, sometimes that date can be inaccurate. In addition, also please include the height and weight, and then please only send 1 echo per web image transmission.
There's an image transmittal form that you guys will be filling out when you upload these, and that has the area for the height and weight on it. Make sure you, like Brent said, you enter those because they have to have those to do the calculations. And like Brent said, double check that the date's correct, because if we lose a transmittal form for some reason, we can always look back at the date of the study to be able to isolate it down to who it was.
And then a lot of times with the presentations, when patients are presented to selection committees and any events committees, there's lots of images and they're easy to get interchanged. So if the date is there, it really helps us keep things straight and it's accurate.
Yeah.
And in terms of valve assessments, so the protocol we're going to talk about today, we're going to give you a list of things that we would like included in the echocardiogram assessment, acknowledging, of course, that studies that you perform may contain additional views or assessments beyond this protocol, and that's totally fine. This is just meant to show the minimum information that we would like to have with each echo. And so we would like you to start the study with the parasternal long axis view. And so that's going to help us assess cardiac size and function. It'll help us get an overall assessment of left ventricular ejection fraction. We can also get an idea of relative sizes of the right ventricle, aortic root, and the left atrium. And then in that same parasternal long axis view of where we have both the aortic and mitral valves in view, please turn on color flow imaging so that we can assess mitral and aortic valve regurgitation. And that's followed by zooming in on the left ventricular outflow tract and aortic valve and imaging that both with and without color so that we can image any aortic insufficiency that might be present and look for aortic valve opening, or if there's any problems with the left ventricular outflow tract, such as presence of a subaortic membrane or some other structure that could cause a problem. And then that's followed by zooming in the same parasternal long axis view on the mitral valve, so we can view the mitral valve and the mitral valve apparatus. And then also in the parasternal long axis view, please tilt the probe to obtain a right ventricular inflow view so that we can use that to assess the tricuspid valve. And you can begin with 2D imaging and then turn on color flow so that we can look for tricuspid regurgitation. And then while in the right ventricular inflow view from the parasternal long axis, please do oh, we skipped ahead. Please do a continuous wave Doppler assessment. That's okay. So that we can use tricuspid regurgitation velocities to estimate right ventricular systolic pressure. And then from the long axis view, please turn to the parasternal short axis view at the basal level, where we can obtain an assessment of the aortic valve, both with 2D imaging as well as color flow Doppler. And then also in the parasternal short axis view, you can move your image to the side so that we can view, again, the tricuspid valve, and we can image that both with and without color Doppler to look for tricuspid regurgitation. And then in that same view, please turn on continuous wave Doppler to measure tricuspid regurgitation velocities, again, so we can estimate right ventricular systolic pressure. And in addition to imaging the tricuspid valve, then move on to imaging the pulmonic valve with a view of the right ventricular outflow tract. And so in addition to visualizing the pulmonic valve, please turn on a pulsed wave Doppler in the right ventricular outflow tract just proximal to the pulmonic valve to obtain flows there. That will help us calculate right ventricular cardiac output. And then, oh, that's okay. Do you want to go back, Michael?
Yep.
And then in this particular image, you can see in the bottom right-hand corner, the heart rate is displayed from a good ECG tracing. And so that we will also know heart rate on this particular image to help us calculate cardiac output. And then also in the peristernal long axis view, move down to now the mitral valve level and image the mitral valve in short axis, both with and without color flow Doppler. Continuing to tilt the probe in the short axis view, we can obtain another short axis view of the left ventricular chamber at the papillary muscle level, so that we can see the location, position, and any other abnormalities that might be present with the papillary muscles. And then moving from these short axis views to the apical window, would like you to obtain an apical 4-chamber view with the left ventricle, left ventricular length maximized to avoid foreshortening of the left ventricle. And it's important that this be a good quality image. This will be one of the images that we use in calculating left ventricular ejection fraction. And so in the 4-chamber view, please obtain a view of the left atrium, maximizing its length so that we can obtain an adequate measurement to assess left atrial volume in the 4-chamber view. And then also we would like you to assess the mitral valve, both with and without color flow Doppler in the 4-chamber view. With that, we'll be able to, of course, look at mitral regurgitation, and we can we'll be able to see any mitral flow acceleration as well, if there's mitral stenosis. And so we would like you to record mitral inflow velocities with both pulse wave and color flow, and continuous wave Doppler imaging. And so when you obtain the assessment of mitral inflow using pulse wave Doppler, please place, and you can see this on the image on the left, please place the interrogation sector at the tip of the mitral valve leaflets, and that should display the image to the right, which is a nice clean inflow velocity profile for mitral inflow. And then also in the 4-chamber view, please now obtain a continuous wave Doppler assessment of mitral inflow velocities. And just a couple of things to note here. Please make sure that the baseline of this tracing is appropriately placed. In other words, we're looking at mitral inflow and not as much at regurgitation on this image. So it's okay to lower the baseline in the image. And then also please make sure that the tracing is expanded as much as possible by using an appropriate velocity scale, so that we trace a larger image, which will minimize any variation in error. And so also in the 4-chamber view, please also obtain a continuous wave Doppler assessment of tricuspid regurgitation. And that's shown on the image on the right, so that we can use the flow, the regurgitant jet velocity to estimate right ventricular systolic pressure. And also in the in the apical window, you can tilt the probe up to obtain a 5-chamber view, and please obtain that with and without color, allowing us to look for aortic regurgitation. And then while in this apical 5-chamber view, we can have you zoom in on the aortic valve and image that with color Doppler to give us a better idea if there is aortic regurgitation and the severity of that if it's present. And while in the apical 5-chamber view, please obtain a pulse wave assessment of the left ventricular outflow tract velocity, and that's obtained by placing the interrogation sector just proximal to the aortic valve in the location where the LVOT diameter is going to be measured, and that will help us again obtain a good LVOT pulse wave Doppler tracing to use in calculating your aortic valve area as well as left ventricular cardiac output. And in this same view, please turn on please turn on continuous wave Doppler so that we can assess maximum velocity across the aortic valve. And this can be done in this 5-chamber view, and we're coming up on a 3-chamber view. If this view is difficult to obtain, then it can be obtained in the 3-chamber view as well. And so with that continuous wave Doppler, we can look at the tracing to help us assess presence and severity of aortic regurgitation, in addition to elevated flow velocities that would suggest presence of aortic stenosis. And again, this can be obtained in this 5-chamber view, or if it's difficult to obtain a good quality 5-chamber view, can be obtained in the 3-chamber view. Moving on to a 2-chamber view of the left ventricle. So again, with this image, you can center the left ventricle in the middle of the screen, and please maximize the length of the left ventricle and avoid any foreshortening. It's also, oh, we're good, Michael. Do you want to go to the next one?
Oh, sorry.
It's okay. It's also important that this be a high quality view, as is important for the 4-chamber view. This will be another data point in our assessment of left ventricular ejection fraction. So and by good quality, meaning just good endocardial definition, and hopefully without lung or other artifact obscuring the image. And so also while in the 2-chamber view, please image the mitral valve both with and without color flow Doppler turned on, so that we can look for the presence of mitral regurgitation. And then while in this apical window, you can obtain a 3-chamber view, both with and without color. So that again is going to allow us to assess for the presence of aortic insufficiency or regurgitation. And while in that 3-chamber view, please zoom in on the aortic valve and image that with color flow Doppler to help us better visualize aortic regurgitation. And then in this same 3-chamber view, you can obtain a pulse wave Doppler assessment of left ventricular outflow tract velocities. And so that's obtained again by placing the interrogation sector just proximal to the aortic valve in the location where you're going to measure the left ventricular outflow tract diameter. And in that same view, please turn on continuous wave Doppler to assess maximal flow velocities across the aortic valve. And in this apical 3-chamber view, we'd like you also to image the mitral valve, both with and without color flow Doppler.
Did the slide advance?
I did. It did. Are you okay there? Oh,
Yeah,
going to go back one?
A little pause.
Sorry. So moving on from there, and can you go to the previous slide?
There you go.
There you go. Moving on from there, please obtain a subcostal 4-chamber view, and then also please turn on color flow Doppler across the interatrial septum to look for the presence of shunt. And then this is also a very good view to assess presence and severity of any pericardial effusion if that's present. And then also, can you advance to the, there you go. Also in the subcostal view, please obtain an image of the IVC, and we can assess its size and look for any respiratory variation, which will help us to assess volume status. And then to finish up the study, please obtain images of the aorta from the suprasternal notch view with both continuous wave Doppler and pulse wave Doppler. and this will allow us to look for flow velocities in the descending thoracic aorta. And I think that finishes up our there you go. That finishes up our transthoracic echo protocol, and would like to briefly go over the transesophageal echo protocol. And that can start with obtaining a mid-esophageal four-chamber view that visualizes the entire heart and the entire pericardium. It's important that the left ventricle be opened up and that it not be foreshortened so that we are able to accurately assess left ventricular function. And then while in that mid-esophageal four-chamber view, please obtain images of the mitral valve by zooming in on the mitral valve and obtaining images both with and without color flow Doppler to help us assess for the presence of mitral regurgitation. And then while in that four-chamber view, please image the tricuspid valve as well, both with and without color flow Doppler to look for tricuspid regurgitation. And then by increasing the multiplane angle to 60 degrees and obtaining a transesophageal two-chamber size, by making sure that the left ventricle is maximized in length and not foreshortened, it will give us good images to again assess left ventricular size and function. And also please zoom in and image the mitral valve both with and without color to look for mitral regurgitation. And then while in the two-chamber view, please also obtain both pulse wave Doppler as well as continuous wave Doppler assessments of mitral inflow velocities, with the pulse wave Doppler interrogation sector again being placed at the tip of the mitral valve leaflets, and then the continuous wave Doppler interrogation line being run through the middle of the mitral valve. And also in this two-chamber view, like we mentioned, also please zoom in on the mitral valve and obtain images both with and without color, which will allow us to better assess mitral regurgitation. And we would also like you to obtain a three-chamber view. And so this is usually obtained by increasing the multiplane angle to around 120 degrees. And this will allow us again to assess left ventricular size and function, and allows us to visualize the, in addition to the left ventricular cavity, both the left ventricular outflow tract as well as the aortic and mitral valves. And then in this three-chamber view, please turn on color flow Doppler so that we can assess aortic insufficiency. And then also with the transesophageal echocardiogram, please obtain transgastric images to give us a short axis view of the left ventricle at the mid-cavitary location at the level of the papillary muscles. This will again allow us to assess left ventricular size and function.
And that's the end of the presentation.
Okay, and just one last image from the transgastric views. We can increase the multiplane angle at the level of the mitral valve to 90 degrees to give us a good view of the submitral apparatus and the mitral valve from the transgastric windows. But that's our transthoracic and our transesophageal echo protocols.
Thank you, Brent, so much. Does anyone on the call have any questions for Brent?
Hi, am I audible?
Yes.
Yes, we can hear you.
Yeah, hi. Thanks very much for the nice presentations, overviewing images. So if I believe the difference between the aortic and mitral assessment, you have included or added two images, two views, that is as the descending aorta and abdominal aorta view, which were not there in the aortic valve. Because in the aortic valve protocol, this descending aortic view and abdominal aorta view was not seen actually. So is there any particular reason adding this to into mitral?
And so Michael and I were looking at the previous protocol. So it was our impression that part of the protocol was the same. So I think that's less important. So I would continue as you're doing. I'd probably not worry about that too much. I guess the short answer is, there's probably no specific need for that. We just thought it was in the original protocol.
So in short, it is almost the same as an aorta, right?
Absolutely. And
yeah.
There's just a few, just making sure that you have with the aortic protocols, we weren't as focused on the mitral valve. So probably the only difference is, really not in protocol, but just making sure that you get high quality images of the mitral valve, including those Doppler assessments.
So you asked for the right ventricle pulmonic valve this time, and you said that you might measure the right ventricle cardiac output. So in that,
by having that,
you do need RVOT zoom more, because if you want to measure the RVOT diameter, because pulse wave we are there. So otherwise you may not be able to see a clear RVOT diameter for measurement of RV cardiac output, as what you said.
Absolutely correct. You are correct. That's a good point. But thank you for noticing. You guys, I'm sure it's very similar to your standard transthoracic echo protocol as is. Right. And if you guys are doing additional imaging, that's great too. And so we just appreciate just all the nice studies that you guys have done. And so all of your questions, your points are fantastic and very, very, very good points to make.
Thank you very much for clearing.
Yeah, and as Brent said, we welcome all the images you want to submit. You guys do a great job with what you're doing. So just there never can be enough images, but there definitely can be too little images. So
I guess, and that's probably particularly true if you get a patient with a mitral valve abnormality that you think may factor into patient selection in terms of what size of valve or whether the patient's a candidate or not. If you feel it's appropriate to include additional images of the mitral valve, please do that. The things we talked about are more or less kind of a skeleton, kind of a minimum number of images, but anything else that you think would be helpful, please include.
Thank you. Sure.
Thank you.
Okay.
Sorry, can I come in?
Go ahead. Go ahead, Uday.
Can I come in, Dr. Uday?
Yes.
Yes.
Yeah, the 4D image is part of study, or it's not required?
I'm sorry, I missed that. Could you repeat the question again?
The 4D images is a part of study or not required? The 4D images of the valve.
Are you talking about the 4D CT images?
No.
He's asking about the 3D echocardiography, actually. Basically, he's asking about 3D echocardiography.
Basically 3D, 4D echo, transesophageal echo images.
I think if you have that would be fantastic. I think we didn't include that because we weren't sure how many sites had access to that. But if you had 3D and 4D images of the mitral valve, that would be incredibly helpful. If you had, could get a whole heart image with that, including that would be outstanding. We just weren't sure how many people had access to the newer machines and could do that.
Right. Yeah. Thank you.
Thank you. That's a great point. Particularly 3D, if you have some 3D TEE images of the mitral valve, that could be incredibly useful as well. We just didn't want to make it overly burdensome.
Sure. Yeah. Thanks.
So my one point is, what about the mitral valve annular calcifications, MAC? Many of the times we notice for the patient having a mitral valve replacement. So any particular view you just select, like a 4-chamber view, zoom more for the annulus to see the MAC, mitral annular calcification, because that plays an important role in replacing the mitral valve prosthesis.
It absolutely does. And this is where we'll have an advantage of having CT images as well. The CT images are going to be very helpful in helping us visualize the mitral annular calcification, kind of how extensive it is, and it will help potentially plan surgical approaches. But from the echo images, like wherever you think is best, I think, whether it's short axis images or some of the long axis images to obtain additional images. If the patient does have extensive MAC, please do what you think is necessary to visualize it. Just knowing that having that CT is going to be a good backup for us to help us fill in any gaps.
And what about the LA appendage views? Sometimes a patient having atrial fibrillation, even patient without atrial fibrillations with a spontaneous echo contrast, and you might see a lot of contrast into the LA appendage. So do we need the LA appendage view for just evaluating the the atrial fibrillations part, or without the fibrillation part, also the velocities of LA appendage?
That's a good question, and we'll talk to Federico, but I think it makes sense to include a left atrial appendage view, particularly if we're doing a lot of patients with mitral stenosis. And like you mentioned, they're going to have more atrial fibrillation, and if there is a thrombus in that left atrial appendage, it may influence the surgical procedure. So that'll be one that we should add, and that's one of the an image of probably an image of the left atrial appendage from the transesophageal echo. And probably also pulse wave assessment of left atrial appendage flow velocities.
Yeah, thank you very much.
Thank you for pointing that out.
Okay, well, thanks everyone for the questions and the great discussion and for your attention. And thank you, Brent, Dr. Brent Wilson, for your help with this morning. Next part of this is going to be focused on Ambra, which is the image repository system that you guys are going to be using to get these CTs and echoes to us. So I'm going to hand over. Chris Wilson is a consultant with Ambra, and he just started sharing his screen. So I'm going to hand it over to him, and he's going to walk through how you guys get these studies uploaded to Ambra so that we can start working on them. Thank you, Chris.
Yeah, you're welcome. So there's a couple ways that we can do this. The easiest is going to be to bookmark foldax.ambrahealth.com. You can also go directly to our generic unbranded page, which is just access.ambrahealth.com. Once you're there, you should have received yesterday information to log in. You're going to put your email information in and a password. The first time you log in, you'll likely need to either do forgot your password link because it's a default. That'll let you reset and get logged in. I grabbed one of our users here, and I'm just using their email to show you what it's going to look like when you log in. Signing in from here, there's going to be fairly minimal amounts of information that you have access to. In the top left is a work list that includes studies that you've uploaded or have been shared to you as a user, as well as, in this case, the India Mitral group. It's the only group of studies that you'll have access to. This is where everything's going to get uploaded for this particular study. Right now, you can see Michael has a test image or an image from the study that's already in here. Everything is automatically being anonymized other than the information that we put in. PII will automatically be overwritten. When you come into this page, the only option you really need is the Add Study button. You're going to have the option to upload. From here, the file picker is going to look at your local system, and you can choose a file that you're going to upload. I'm just going to grab a random file from my computer here. Keep in mind that this needs to be DICOM, like we discussed previously, for it to ingest properly. Also, if you select something, it is going to do a hierarchy down from your selection. So if you just select your C drive or your hard drive, it's going to find every DICOM file in there. So make sure you're looking at the specific folder where the study you want to upload is being referenced from. It's going to do a quick scan and tell you the information that was present in that particular study. Now, obviously, this is going to look a little different for you. We have a few questions that we need you to fill out prior to uploading. These may look different by the time the actual study starts, but ultimately anything that's on here needs to be recorded. In this case, I'll put the user that we're logged in as. Again, site number, patient ID, this might change. Ultimately, I'm just going to put site 1, patient ID 100, and then the time point being where it's at in the process currently. We'll mark it here as just our 30-day for the moment. Once you hit upload study, you want to wait until that progress bar gets completed and you actually get an uploaded congratulations message. At that point, when we go back to studies, you're going to see your study beginning to upload here. You can sit on this page and wait for it to refresh. You'll see an indicator that says the study has been successfully updated. So we have the one new. Once I refresh, you'll see all of that information that was previously on that study has been anonymized, and the information that I entered, for instance, the patient ID number and the study stage, is here in the study. You do have the ability to go to the image viewer so that we can see and confirm that the study that you uploaded is the correct study. Closing out of here, the other thing that is very important is after this study is uploaded and you confirm that it's here in Ombra, make sure that you go to the reports section and hit an upload to upload your reports. This is going to also bring up a generic prompt for your computer where you can select a file. I'm just going to grab a random PDF here. And then once you select that, you'll see the report on this screen. That's
And
the
Chris,
basics through login.
Go ahead and Chris, you can show them the report I uploaded on the test when I did. Because
Okay.
what Chris is referring to here is the image transmittal form, which is imperative for us to know, what study this is and the patient's height and weight that we discussed earlier. So there you go. That would be an image transmittal form. This is just an example of one of them, but you'll have one for
Right.
echo and you'll have one for CT.
And in this case, we would expect that drop down to say discharge to match what is being seen in your transmittal as well.
Yeah.
So I'll close this out. That opens a second form, but you can see here anything that's been attached as a report will show up under that drop down. If I refresh this, my generic PDFs there on that study as well. But ultimately, that's the process you're going to take. Log in with your email. You will only have India Mitral as an option. So you just do your add a study, upload your DICOM, upload your report, and you should be done.
And under the India Mitral, Chris is going to set up so you'll see each one of your accounts, 0, 1, whatever account that is, 0, 2, whatever account that is. So all the sites will be listed underneath that, and then you'll just be uploading things through your site.
Anyone have any questions on the Ombra uploading?
I know historically some of you on the phone call have been using Bioclinica. That was what we used with our aortic study in India. We have decided to move forward with Ombra. It's much more user-friendly. The Bioclinica platform required you to have to zip your images before you, the files before you uploaded them, which we ran into a lot of issues with zip formatting, as simple as that may be. It had to be a WinZip format, and if you were using an older version, it could corrupt the images. Just Ombra is, it seems to be faster and much more straightforward and user-friendly, so I hope you guys enjoy using it. Chris, is there anything else you want to cover on the Ombra platform, or that's the main part I wanted you guys to get to know how to upload a CT or an echo?
No, I think it should be good. I think ultimately, like I said, everyone should have received an email giving them information saying they were invited to the Foldax Ombra platform. Please make sure you click on the link in that email so that you can finish the registration for your account. Ultimately, the login information is your email and then the password that you'll set once you log in the first time.
So look for that email, get yourself set up, and you'll all be ready to go. And of course, if you have any questions, you can always reach out to me. The Manisha and Anju and Pooja and everybody in India are there for you anytime you need them. They relay directly right back to me. You can also reach out directly to me anytime you want. And then we've got the wonderful expertise of Dr. Wilson and Dr. Federico Ash, who isn't with us, and Chris Wilson from Ombra, here to help you guys anytime you need it. Any questions? Well, I guess that concludes our core lab training for this morning. I appreciate everybody's attendance, participation, the great questions, and really looking forward to doing this mitral study with all of you. It's got a great future with both the company and with forwarding valve medicine around the world, India and specific.
Yeah.
Thanks, everybody.
Thank you very much, Michael.
Okay.
Brand. Thank you very much. Thanks, team.
Thank you guys so much. Have a great evening, sleep tight, and have a great day tomorrow.
Thank you.
Thank you,
Thanks.
everyone.
Thank you.
Thank you, everyone. Thank you, Brent and Michael. Thank you so much.
Thank you.
Thank
Bye-bye.
you.